Hello, this is Tom Davis, Partnership Leader for Health and Nutrition for World Vision International, and this presentation is on leveraging nurturing care groups to end violence against children. I want to talk to you today about a project model that World Vision has been using to help end violence against children called nurturing care groups. The NCG model uses a highly successful care group approach to promote behaviors at the household level across all 5 domains of the nurturing care framework. The care group approach upon which this model is built has been shown to lower child deaths by 32% at low cost, reduce malnutrition by 38% in some settings, and when it was compared to other CHW-led behavior change approaches in 5 countries, it achieved double the behavior change and 53% better reduction in child deaths. I was a co-pioneer of the care group approach, and in World Vision, we decided to use it to see if we could get the same sort of results that we were seeing in health, nutrition, and WASH by applying it for reducing violence against children. With this project model, governments and organizations can choose from different behaviors to promote across the 5 domains of the nurturing care framework based on current adoption levels. Dr. Henry Perry and I have been making the case over the past few years that if we want to scale up the nurturing care framework and the Thrive agenda, we need to have more and more countries using 2 tiers of community health workers. The current tier, who often work a few days a week or full-time, and eventually they should all be paid, and a second tier of volunteer community health workers who can focus mostly on behavior change with limited hours, about 8 hours a week or less. Without these 2 tiers, I don't see how we can address all of the things that we need to address to achieve the goals of the nurturing care framework without severely overloading community health workers. With the nurturing care group model, you start with a census which targets all households or every household with a beneficiary. For example, pregnant lactating women and children under 2 or under 5. There's flexibility on which households are included. Next, the caregivers in each group of about 10 to 15 households, see the far right here, select a second tier volunteer community health worker who will serve them. These nurturing care group volunteers are then trained every 2 weeks in groups of about 12, either by a paid nurturing care group promoter who works with about 5 to 9 groups, or a first tier community health worker who works with only 2 groups of volunteers. The groups of volunteers are the nurturing care group, and the groups of caregivers are often called neighbor circles. The nurturing care group promoters are supervised by a supervisor who is usually a health facility staff member when a community health worker is in the nurturing care group promoter role. The nurturing care group volunteers learn a new behavior promotion lesson every 2 weeks and then cascade that down to the households that they serve. So it's essentially a behavior promotion platform. In this test of the model in Ghana, our staff promoted 6 child protection behavior change lessons shown here, which focused on reducing harsh punishment and dealing with caregiver stress. I've shown a few of the images from the flip chart as well. Since a new behavior is promoted every 2 weeks, the volunteers were able to complete this module in about 3 months. The same volunteers also promoted WASH behaviors in this project and had excellent results there as well. We have a full set of 15 publicly available NCG lessons to promote child protection, safety, and security, along with 51 other lessons to promote other sector behaviors. These lessons align with the Inspire framework, and the objectives of those lessons are shown here. I won't go through all of these now, but note that they include lessons around preventing child marriage and child labor, and recognizing and reporting violence against children. And we are also beginning to train all of our 186,000 community health workers worldwide in how to recognize and report violence against children. We used a quasi-experimental design for this study in Ghana, comparing intervention areas in Savalugu and Sekiere East municipal areas of Ghana with nearby areas that did not receive the nurturing care group intervention. We used a controlled before and after trial to limit bias in assessing program impact. And we calculated simple difference in differences to assess changes over the duration of the program. So comparing the change baseline to final in the intervention area with the baseline to final change in the control area. Substantial changes were seen in the intervention group, despite the fact that this study took place with one of the most significantly counting events in history taking place, COVID-19. And while it's not possible to disentangle potential interactions of COVID-19 and the intervention, for example, perhaps there were synergies between program messages and motivation due to COVID-19, the differential impact of the program given the context is clear, as you'll see. So here's what we found when we compared caregivers reached via the nurturing care groups and those who were not. Caregivers reached with nurturing care groups were less likely to use 8 different forms of physical violence against children. For example, to shout, yell, or scream at him or her, a difference of 23 percentage points between intervention and control. To call him or her dumb, lazy, or another name. To shake him or her. To hit him or her on the bottom or elsewhere on the body with a belt, hairbrush, stick, or other hard object, which was a 25% point difference between intervention and control. To slap the child on the face, head, or ears, and to beat the child up. Nurturing care groups reach caregivers were also more likely than controls to often or always praise the child in 6 specific ways that are shown here. They were also more likely to know and practice parental relaxation techniques such as slow and deep breathing, stretching, imagining a favorite place, or singing a relaxation song, or counting backwards from 20 to 0. We did not see any significant changes in use of some parenting techniques that we promoted, such as use of timeout and taking away privileges. Caregivers reached with nurturing care groups were also more likely to inspect their house for safety issues, but they weren't more likely to take action on those safety issues, so we need to reinforce that lesson. They're also less likely to say that the punishment that they give depends on their mood, and they were more likely to report often or always doing 8 different positive things with the child, such as volunteering with their activities and sports, playing games with them, asking about school and homework, and inviting the child to help plan family activities. We saw much better increases in knowledge and beliefs that changed as a result of being reached through the nurturing care groups, but I won't go through all of these. One of the best things about this model is that it's easy to add on your child protection work to other sector work. Note that all of this child protection promotion work in Ghana was largely led and carried out by WASH staff. So along with the remarkable results we saw in reducing harsh punishment, our WASH staff were happy to also see significant improvements, the green lines, in water quality, hand washing, and other hygiene indicators as compared to the controls. As we think about the future of the child protection sector, we need to think about how to better leverage behavioral science. NCG's work in part because they're based on behavioral science findings, including the work of Richard Cialdini, William R. Miller, Albert Bandura, Daniel Kahneman, and others. And we often use barrier analysis alongside of nurturing care groups and care groups, which can produce even better results. We need to be looking at metrics such as cost per behavior adopted as well. We also need to do better measurement and control of comparison groups in our child protection evaluations and research. While we had much larger changes in the intervention group in the Ghana study, and about 87% of the indicators improved among those reached with nurturing care groups, about half of the child protection indicators improved in the control group. Lastly, we need to be paying attention to coverage and costs of different models to end violence against children. This model reaches caregivers of children about 20 to 26 times a year, with about 85% or more of caregivers reporting contact by a volunteer within the past 2 weeks, both through home visits and group meetings. And it has a cost of only $3 per beneficiary per year, US, and a cost per behavior adopted of about 85 cents. So we need to benchmark other models against this and continuously test and improve our models. Here are some links to the materials that we used, and feel free to reach out to me or my World Vision Child Protection colleague, Bill Forbes, to learn more about this work. Thank you.